Good afternoon and welcome to the Acute Hepatic Porphyria, bridging gaps for better diagnosis and management. For this presentation today, we would like you all to follow with the QR code, especially for everyone who's doing this from home in front of their home computer. Please log in. Please answer the questions. We're trying to get a good feel of where people are coming from, their careers, where they're at, how many patients they take care of with acute hepatic porphyrias, and also to help with the question and answering session at the very end, and then in between. So we appreciate all you guys being here today and hope to have some fun, so please log in and ask questions throughout. Today we have a great group of speakers. Essentially, all of us are part of the Porphyria Consortium, which is a great group that's been formed really to help with the diagnosis and management of patients with acute hepatic porphyrias. We have, to my left, Rebecca Karp. She's coming here from Mass General. And on my far left is Akshata Mogi, who's coming from UT Texas Health Science Center in Houston. Essentially, this is an agenda of what we're doing today. This is the introduction. Rebecca will start with awareness, defining gaps in current practice patterns for acute hepatic porphyrias. Then Dr. Mogi will go next, and she'll talk about disease management. And then I will go last and talk about real-world implications to care. And then we'll have a question and answer session after that. So if we're all ready, let's go. Dr. Karp, please start.
Hi, everybody. It's great to be here and really nice to see some friends and colleagues that are in the audience. So thank you guys for coming. So first, we're going to start with a case. So this is a 24-year-old woman who presents with blistering skin lesions over her face and the dorsum of her hands, as well as facial swelling. And 2 years before, she had placement of a progesterone-only IUD for heavy menstrual bleeding, and then she first noticed blisters and cider-colored urine at that time. 4 months prior to presenting, she was started on combined oral contraceptive pills for persistent heavy menstrual bleeding, and her blistering worsened, and she developed facial swelling, and her urine remained dark. So she had a skin biopsy of one of these lesions, which showed subepidermal blister consistent with Porphyria cutanea tarda, or pseudoporphyria. She also endorsed periodic abdominal pain that was worse just prior to her menstrual period, and her liver function studies, her AST and ALT, were elevated at 8 times the upper limit of normal. And so here were her labs. So you can see her urine biochemistries. There were elevated, highly carboxylated porphyrins, uroporphyrin, hepta, hexa, and pentacarboxyl. Her PBG and ALA in the urine were within normal limits. She had high levels of plasma porphyrins, mostly copro, as well as penta. And then in her stool, she had elevated copro-3, and her copro-3 to copro-1 ratio was elevated. And then her genetics were consistent with a pathogenic variant in PPOX, which is located on chromosome 1, and this is consistent with a diagnosis of variegate porphyria. So what is porphyria? Let's just review. I know a lot of us have studied this in medical school, but it's always helpful to review. So porphyria is a family of 8 distinct diseases arising from defects in heme biosynthesis. And porphyria happens due to a blockage in that pathway when toxic heme intermediates build up and lead to symptoms. So I kind of think of it as an assembly line or a river. So say it's an assembly line, and at the end of the assembly line, you're making heme, or let's call heme cars. Let's say you're making cars. And then each step is a step in making that car. So let's say step number 3 is you're putting the wheels on the car. But step number 3, or enzyme number 3, isn't working as well. And if you have an increased demands for cars or an increased demands for heme, and you sort of rev up that pathway, there's a blockage, and there's this backflow, this overflow, this bottleneck at that step, and you have a buildup or a backup of all of these toxic porphyrins and porphyrin precursors. So here are the types of porphyria, and there are 3 broad categories. So there's acute hepatic porphyria. The quintessential one is AIP, or acute intermittent porphyria. Blistering cutaneous porphyrias, like PCT, Porphyria cutanea tarda. And painful non-blistering cutaneous porphyrias, like EPP and XLP. And these are clinical characterizations. We also talk about where heme is synthesized, and porphyria is based on the site of porphyrin accumulation. So here is the pathway of heme biosynthesis, and after each enzyme, you see what type of porphyria is associated with a variant in that enzyme. And 80% of heme is synthesized in the bone marrow, and then about 15 to 20% is synthesized in the liver. And as hematologists, we always think about heme as important for hemoglobin and oxygen transport, but heme has myriad uses and responsibilities in the body, including a lot of metabolic processes, electron transfer, gas sensing, circadian rhythm, and microRNA processing. So heme is ubiquitous, and heme is important. So again, here are the types of acute hepatic porphyrias, because today we're talking about the acute hepatic porphyrias when you have a buildup of porphyrins or porphyrin precursors in the liver. So there's acute intermittent porphyria, again, that is due to a pathogenic variant in hydroxymethylbilane synthase, or HMBS. It's autosomal dominant inheritance, and patients present with neurovisceral signs and symptoms. It has a prevalence of about 0.5 in 100,000 people, but the penetrance is much, much lower. So many people will have the gene, but very few of them will actually be symptomatic. Variegated porphyria, which is what our patient has, which is a variant in protoporphyrinogen oxidase, or PPOX. Hereditary coproporphyria, or CPOX, and then the very rare ALAD porphyria, which is a pathogenic variant, or 2 pathogenic variants in ALA dehydratase, and that's the only one that is autosomally recessive, inherited. And all of these can present with neurovisceral symptoms. Variegated porphyria and hereditary coproporphyria can have cutaneous symptoms as well. And ALAD porphyria can present with hematologic complications. So delay in diagnosis. So why is it so difficult to diagnose porphyria? So the average delay in diagnosis is 8 years, but it can be up to 15 years or even higher. So symptoms are very nonspecific and can mimic other conditions. The porphyrias are often glossed over in medical school. I think I probably had a day or half a day on the porphyrias in medical school. There's a lack of provider education and awareness, which is, of course, why we're holding this meeting today. Lab tests may only, or sometimes only elevated during an acute attack, so it's hard sometimes to capture those positive biochemical results. And then on the flip side, if patients are tested for porphyria, they may have minor elevations in porphyrins and precursors, but they're not clinically relevant. So the testing can be a little bit confusing at times. However, overall, the delay in diagnosis of the acute hepatic porphyrias is decreasing, and this is probably due to more awareness, due to the development of new medications, patient advocacy groups, and easier access to genetic testing. So what causes an attack of AHP? So ALAS1 is the first and rate-controlling step in heme biosynthesis in the liver. And so you can see heme over there, and you have succinyl-CoA and glycine as the building blocks to making heme. And so you have ALAS1, that first and rate-limiting step, and if you induce ALAS1, and we'll talk about various factors that can induce ALAS1, again, in the presence of that blockage, that bottleneck, you can have a buildup of those toxic heme precursors. So what sort of regulates heme in the liver, and what might induce ALAS1? So multiple drugs and hormones can induce ALAS1. So the prototypical one, or the quintessential one, is progesterone, which induces ALAS1. Drugs that induce CYP450s in the liver, you need heme as a cofactor. So if somebody is with porphyria is started on a medication that is metabolized by a CYP450, that ALAS1 is induced to make more heme. Nutrition and metabolic states, so low glucose can induce transcription factors that again induce ALAS1. High glucose, on the other hand, can suppress ALAS transcription. And then there are multiple factors that reduce in negative feedback by heme. So here are some factors that we think about commonly. So stress, fasting or a low caloric intake, certain medications, alcohol, and then progesterone. So again, drugs and steroid hormones can directly induce ALAS1 expression, and then fasting, stress, alcohol, et cetera, can increase the demands for heme that subsequently induces ALAS1. And then porphyrinogenic medications, so this is one way that we can really help our patients is by reviewing their medication list and going over any new drugs that they are started on. So you ask yourself, or you look up, does this drug induce CYP? And ask your pharmacy colleagues for help. And there are some very good databases listed here that will tell you whether or not a drug is safe or unsafe for a person who has acute hepatic porphyria. So what are some symptoms of acute hepatic porphyria? So there is autonomic dysfunction, so abdominal pain, constipation, nausea, tachycardia, hypertension, peripheral neuropathy, numbness, weakness, respiratory muscle dysfunction, CNS dysfunction, so seizure or even press. For some porphyrias, you can have blistering skin lesions like our patient had, and then this reddish urine and fatigue. And actually, porphyria actually means purple, or is derived from the Greek word for purple because of this purple-colored urine. Oh, let me go back. So as I mentioned, many of these symptoms are very nonspecific, right? Abdominal pain, neuropathy. I always say to patients, if somebody comes in with a broken leg, the orthopedic surgeon knows, okay, it's a broken leg, I put a cast on it. Somebody comes in with abdominal pain, neuropathy, seizure, it's a broad diagnosis. So when to suspect AHP, really have a low threshold to suspect and a low threshold to send testing, and we'll talk about that in a minute. And the differential diagnosis is broad. So Guillain-Barré, and patients who are diagnosed with Guillain-Barré have porphyria on the differential as well. Heavy metal poisoning, so certain metals like lead can produce biochemical and clinical symptoms consistent with acute porphyria. Cyclic vomiting syndrome, cannabis hyperemesis syndrome, gastroparesis, small fiber neuropathy, and pheochromocytoma. And then why do some patients with VP and HCP have cutaneous symptoms? So really patients with AIP, acute intermittent porphyria, don't have these blisters and the skin fragility that we see with variegate porphyria and hereditary coproporphyria. So patients with VP and HCP spill porphyrins that are lipophilic into the blood, and they circulate in the superficial dermal vessels where they react with the sun and generate reactive oxygen species, inflammation, and complements. And then again, this causes the cutaneous blistering that we see in these disorders, but that doesn't happen with AIP. So the laboratory diagnosis, if I didn't say it before, have a low threshold to test. So somebody comes in with unexplained abdominal pain, neurovisceral symptoms, et cetera, often in a young woman of childbearing potential, but it doesn't have to be. First-line testing is a spot urine PBG, or porphobilinogen, normalized to urine creatinine. Some labs will automatically normalize to urine creatinine, but make sure to send it just in case. You might also send a spot ALA and urine porphyrins. And then the PBG result, when somebody is really having an attack, it's not subtle. There is no ambiguity. AIP with an acute attack, that urine PBG is 20 to 200 times the upper limit of normal. So it's very high. And multiple labs across the country will send this testing. So second-line testing, so additional tests we often would send, on the right of the screen you can see PBG deaminase, fecal porphyrins, and this plasma fluorescence screen. But over the past few years, we've had really easy access to free genetic testing, which has truly shaped our ability to diagnose and care for these patients. Genetic testing can confirm a diagnosis and identify the subtype of porphyria, and we can also test at-risk family members. So we're not going to go through this whole slide, but this just shows us the variability in AHP symptom presentation. So patients can have active symptomatic disease, multiple attacks throughout the year. Patients can have high levels of PBG and ALA and have no symptoms, or high levels and have chronic symptoms, but symptoms that don't rise to the level of an acute attack. Patients can have latent or inactive porphyria, so they have the gene, but they've never had symptoms. And so this really runs the gamut when you see these patients. So what's the impact of AHP on specific health domains? So this was a study that was published in 2022 looking at over 90 patients across 6 different countries and trying to quantify quality of life measures in patients with acute hepatic porphyria. And these were patients who were both on treatment prophylaxis or no prophylaxis, which we'll get into later. But you can see that the majority of patients had reported that their physical, emotional, cognitive, financial, and social health was either fair or poor. So we know that we have to do better with this patient population. So what is the burden of AHP, and how do we monitor these patients? So many patients with recurrent and sporadic attacks experience chronic symptoms. So some patients can come in to the hospital with an acute flare, but oftentimes people can have, in the background, just these symptoms that don't rise to the level of an acute attack, but they're chronic and they can really impact quality of life. Furthermore, on specific treatments, which we'll discuss in a bit, urine biomarkers, ALA and PBG, may not accurately reflect disease activity, and sometimes it can be hard to diagnose acute attacks in patients on treatment. And then long-term follow-up, so we make sure that everybody has yearly renal and kidney function studies. Patients are at risk for high blood pressure, so we monitor their blood pressures. And patients over the age of 50 are at very increased risk for development of hepatocellular carcinoma, so we do abdominal ultrasounds every 6 months in these patients. So there's an increased risk for HCC. And this is a bit of an area that is near and dear to my heart. I think that this is one of the topics in AHPs that we really need to do better with, which is reproductive health in acute hepatic porphyria. So AHPs are autosomal dominant, yet most symptomatic patients are female, so 90% of patients who have symptoms are female, even though because it's autosomal dominant, the genetics are split 50-50. And this skew has been attributed to hormonal factors, particularly progesterone, like in the luteal phase of the menstrual cycle. And as we said, progesterone or progestins can act as inducers of ALAS1 and CYP450s. And so despite AHP primarily affecting women of childbearing potential, little is known about the effect of reproductive factors and hormones on AHP. So this is, again, something that we need to do better in, and we actually have an oral presentation on Monday afternoon about reproductive health in AHP. So this is our woman. I'm just going to have So 1 second. So she stopped her combined oral contraceptive pills, and a copper IUD was placed instead. So a copper IUD doesn't have any hormones. She actually did not receive any other AHP-directed therapy, again, which we'll review in a bit. Within 2 weeks of stopping the contraceptive pills, her abdominal pain and dark urine subsided. Within 4 months, her blisters resolved. During the summer, she would still, though, have some blistering on sun-exposed skin. And she recently had her first baby, and she had no complications in pregnancy. And in fact, she felt better during pregnancy despite the high hormone levels than she does at baseline, which I thought was very interesting and, again, needs further study. And her plasma and urine porphyrins improved during pregnancy, again, despite these high hormone levels. So what is the hematologist's role here? So again, have a low threshold to test. Urine PBG normalized to creatinine. Just send it. Understand what constitutes a positive and a negative biochemical test. Confirm biochemical testing with genetics. Familiarize yourself with new medications. Again, we're going to discuss these. Make a plan for your patients with AHP so that when they show up to the emergency room, they're treated appropriately, or when they call your clinic, you don't have to admit them to the hospital. Perhaps you can treat them as an outpatient. Educate your colleagues in different specialties who may see the patients first, and call a friend in the Porphyria community for help. We are always talking to each other. These are complicated patients. There's often not a right answer, and we really welcome any questions, any collaboration, and it's really a privilege to be able to be part of this community. So thank you very much.
Thank you very much, Dr. Karp. Really appreciate it. And your comment about having people call us, and I'm sure you've talked to people from other countries too. It's nice having that ability. Anyone who calls us or reaches out to us, they want help. You know what I mean? And they're trying to help patients, and that's why we're all in this game together, aren't we?
Yep.
Yeah, it's fun.
And we learn from everybody. You know, everybody does things a little bit differently. So, you know, I'll call Shada and say this, or I'll call Brendan and I'll say this.
Yeah.
And, you know, so it's nice. It's a very collegial group, yeah.
It's a great group. I agree with that. So we have a few questions here. Some of the questions will be directed towards treatment and things like that, so we'll come back to them. I guess some of the questions, let's start with this one. So new drugs that are just out on the market, that we have no data and they're not in the databases, what do you tell your patients?
So that's very, you know, that's difficult. So again, you want to see if this is a drug that induces CYPs in the liver, you know, CYP450. So that's really going to tell you whether or not this drug is going to cause problems. You know, we have a colleague who's out at UCSF who's really studying, you know, a lot about the drugs and porphyrinogenic medications. So I've often asked him if I've had questions, and this was actually an issue, you know, with the GLP-1 drugs, because, you know, our patients, like all patients, are asking if it's safe or unsafe, and we went through it, and it actually looks like in patients who are fairly well controlled from a porphyria standpoint, that, you know, it's probably reasonable for them to try these medications. But oftentimes we don't have the best answer for these new medications, but learning the mechanism, thinking about the mechanism can be helpful.
Yeah. Do you ever tell them, because sometimes I will tell them, start a drug, and let's just repeat urinary ALA and PBG in a couple weeks and see what happens. Have you ever done that?
Yeah, we've done that. You know, I've done that with certain birth control for patients, you know, birth control that contains progestin that perhaps they need to take for some reason. And we say, listen, you know, we know what an attack looks like for you. So A, of course, call me if anything happens. And B, let's sort of monitor your biochemical tests over time to see if there's any change.
Yeah, that's fair.
But sometimes the benefit of taking a drug, even if we don't know, you know, what it's going to do, outweighs the potential risk. And it's always this sort of balance in medicine in general.
Yeah, and we can always stop it if need be, and usually then everything will resolve anyway.
Exactly.
Yeah, just in case we get in trouble. I agree with that. Another question is, I'm evaluating patients for acute hepatic porphyrias, and a lot of them have non-specific porphyrins. What do I tell the patients they're from?
So that's a good question. So, you know, multiple conditions can cause these sort of non-specific mild elevation, in urinary porphyrins, and that does not a diagnosis of acute hepatic porphyria make. We showed in one of the slides that it is not a subtle diagnosis. When somebody has an acute attack of hepatic porphyria, their urine PBG is really elevated. It's not sort of this borderline or, right above the upper limit of normal. It's high. It is very high, 10, 20 times the upper limit of normal. Sometimes it's difficult to discern, and then genetics can be helpful as well if there's any ambiguity. If you think, well, maybe the levels are a little bit higher than I would expect, you send the genetic testing. But biochemical testing coupled with genetics, should really rule in or rule out a diagnosis.
That's fair. And this question, I promise I didn't write it because I know we've talked about it. Fecal porphyrins.
Yeah.
Do you order it?
So you know what? Now that we have, so fecal porphyrins is really helpful for VP or HCP, but we don't routinely order it now that we can have fast and easy access to genetic testing. It's less important. In this patient, it was the first time she was presenting, and we were trying to get sort of a whole picture of her, and we just wanted to see what the fecal porphyrin showed. But in general, we don't send it if we have a PPOX or CPOX mutation, and the urine and plasma biochemistries are consistent with a diagnosis. Probably don't need to send it. You need to send plasma fluorescence. I mean, in some cases it can be helpful, but vast majority, genetics and the urine and plasma is what we need.
Very good. And to emphasize your point too, it's really just a spot test. You don't need to do a 24-hour. I still see people getting 24 hours urine tests.
Yeah,
Very good.
Yeah.
Okay, and one other question. Why do patients with Dubin-Johnson not have porphyria symptoms since they have a problem with porphyria excretion?
I would ask you that as a
As a
hepatologist.
hepatologist. That's more pediatric. I don't deal with that at all.
That I can't tell you.
Yeah, I don't know the answer to that either.
No.
But it would, it's an issue, right, with bile transport.
Yeah.
And it still would be the type of transport, but they still should be able to pass it out. But they're at levels I would not expect would be as elevated. I would assume anyone with cholestatic liver injury, like this would be, I assume they'll have even mild elevations throughout the pathway.
Yeah.
You agree with that, Dr. Mogi?
Yeah. I think
Okay.
so.
That's
Good.
my hepatology colleague.
That makes sense. That logic makes sense.
Okay, very good questions. Thank you, guys. Keep the questions coming, okay? We may not have the answers, but we'll make up something. We're okay. Okay. And next, Dr. Mogi will speak on disease management and therapeutic advances for acute hepatic porphyrias.
Okay, so I'm Akshita Moge, and welcome everybody to this segment, the next segment in our session. And I'll be talking about disease management and therapeutic advances in acute hepatic porphyrias. We are going to dive in right away with a case. So this is our case. This is a 34-year-old woman. She's presenting with 2 weeks of severe, intensifying, diffuse abdominal pain. It started 2 weeks ago. It started kind of as a dull pain, but it's been getting worse. It's progressive. It's now a 10 on 10. She's presenting to the ED. When she comes to the ED, we get a little bit of her past history. So her only medical history is really only migraines. She's otherwise fairly healthy. She had a C-section. That's her only surgery. That was 5 years ago. Family history is interesting. She has a history of recurrent abdominal pain in her father. And her father doesn't have a diagnosis for this pain. He still gets this recurrent abdominal pain. She also has a history of colon cancer in her maternal aunt at a young age of 31. She's married. She has a 5-year-old daughter born with the C-section. She's a homemaker trying to set up a side business of photography. And she does not use alcohol, no smoking, no illicit drugs. Her only home meds are cyclobenzaprine, 10 milligrams thrice a day, and acetaminophen hydrocodone as needed. So coming back to her presentation, so she reports that her pain has been progressive, now a 10 on 10. It started somewhat in the epigastric region, radiated to the flanks and to the lower abdomen. It was initially diffuse, but now she has this sudden, sharp shooting pain That happens at times with the diffuse pain present at baseline. No relationship to any food intake, and when asked about her pain, she says she also has this low back pain that is radiating to her feet. Now, she's had these episodes of abdominal pain with the low back pain a few times over the past few years. In the past year, she's presented to the ED a couple of times for this. Sometimes it's just lasted a few minutes and she stayed home. But this is not something new for her. This presentation, though, before 3 weeks before the pain started, she was diagnosed with a UTI, and for that she was treated with trimethoprim sulfamethoxazole, which she completed a course of. On review of systems, she also has nausea, some occasional emesis, reports that her appetite has kind of decreased, she feels constipated, and she's lost 5 pounds since the symptom onset 2 weeks ago. And she also reports that her urine looks red. She thinks she has hematuria. On physical exam, she is afebrile, but she's very hypertensive. Her blood pressure is 179/118. She's also very tachycardic with a heart rate of 144, otherwise breathing fine, saturating well on room air. And she has a normal BMI. She looks like a well-grown young woman, but kind of dehydrated with dry mucous membranes. Her abdominal exam is soft. She has a soft abdomen. It's not distended, but she is tender to palpation all over the abdomen, especially on the right side, with some reduced bowel sounds. She has no guarding or rigidity, so there's no concern for peritonitis or those kind of GI issues. She also gets a neurological exam because of the radiating leg pain, and she has a normal exam, no jaundice, no stigmata of chronic liver disease, no CVA tenderness. So at this point, she also gets labs. And we have some labs that are showing here. She gets a BMP, a basic metabolic panel. She also gets lactate and amylase and lipase ordered to see if this is pancreatitis, a CBC, iron studies, and also a pregnancy test. And really, all of it is normal. Everything comes back very normal. So there's no clue there as to what's going on. She also gets a urine analysis because she reports this red urine. And her urine, when reported, the urine analysis on the report reports a hazy orange color with some white cells, some red blood cells, some squamous epithelial cells, 1+ bacteria. But there's this comment on the report that says substances that cause abnormal urine color may affect the readability of the reagent test strips. Due to intense urine color, the results of focal blood, leukocyte esterase, nitrites, glucose, urobilinogen, protein, and ketones were not reported. So this was something unusual. We've never really seen that on a report before. She gets a CT, abdomen, pelvis. Again, no clues there. Everything looks normal. She gets a pelvic ultrasound to see if this is ovarian torsion. That's normal as well. So at this point, there's no diagnosis to this pain. She gets treated symptomatically in the ED with IV hydromorphone, IV and ondansetron for the nausea. And she improves a little bit, but not significantly. So at this point, with the pain not having resolved, she's still tachycardic. The decision is made to admit her. She gets admitted to the medicine floor for management of uncontrolled pain and the UTI. So on the floor again, the house staff team is trying to manage her pain, so she gets de-escalated actually from IV hydromorphone to IV ketorolac. She's on IV normal saline, so fluids for the tachycardia, and a repeat urine analysis has been sent to see what's going on in the urine. Now, a day into the presentation, the next day, in the middle of the night, she has an event. Her husband wakes up to choking sounds coming from her, the patient. The patient looks unresponsive, so he causes alarm. There's a rapid response team that is called to the bedside, and they note that she's now nonverbal. She has bilateral nystagmus, moving all limbs simultaneously. So this looks like she's in a seizure. She's having a seizure. Vitals still show that she's afebrile, but she's still tachycardic, still hypertensive. Now she's also breathing rapidly, and her oxygen saturation is a little bit lower. Her husband also reports that earlier in the day, she was hallucinating. She was seeing horses on the wall, shapes on the ceiling, so she was not herself during that day. Now, labs that are drawn at the time of the event are notable for a very low sodium, a sodium of 117. And if we looked at the labs from presentation, her sodium was 136 when she presented. So a big drop in the sodium. All other labs are unchanged. So now she gets transferred to the MICU for management of this hyponatremia, acute hyponatremia, generalized tonic-clonic seizure. In the MICU, she remains hypertensive and tachycardic despite intensified treatment measures. Her labs in 4 hours show that the sodium is falling even further. It's now 110. And the urine analysis that was sent, the urine looked reddish, but there are no red blood cells in the urine. She gets a CT head to see if she had any stroke or anything that caused the seizure. It's negative. CT chest for pulmonary embolism is negative. She's hooked up to an EEG that shows just mild diffuse encephalopathy, no seizure activity. So at this point, this is a multidisciplinary team effort, and the nephrology, gastroenterology, and neurology teams are all consulted. And we're thinking about what might be the differential diagnosis because it's not very obvious. So the MICU team at this point was thinking about, they initially thought about cyclobenzaprine toxicity because that was one of the 2 meds she was on. And cyclobenzaprine toxicity can give you tachycardia and hypertension, sometimes seizures. Really can't explain why she came in with abdominal pain. So it was on the differential, but didn't really fit. Vasculitis is, I think, always on the differential when you don't really know what's going on. So that was being considered. But then somebody on the team was considering acute hepatic porphyria. And what does everyone think is the diagnosis here? I think we all know because we are at a porphyria talk that this case is probably a presentation of an acute hepatic porphyria attack. But if we are suspecting that, how do we proceed? What do we do? How do we test? So the diagnosis of acute hepatic porphyria, as I like to say, is very simple, but also somewhat difficult at the same time. So it's simple because it's a single test. It's a single random urine sample that we send for porphobilinogen. It should be normalized to creatinine. So if your lab doesn't do the creatinine, usually we also send a urine creatinine, but it's on the same sample. We do not need a 24-hour urine. We don't need any other test. So a single random urine sample. The reason it's difficult to some extent is because there are some logistics involved. Most of the time, this is not an in-house test. This is a send-out test. But there are several labs that do this test. So really, it should be available to everybody. And when we send out the sample, we protect the sample from light and heat because we think that light and heat can destroy some of our results, can destroy the porphyrins. So this patient gets this test sent out, a single random urine sample. We test it for PBG, and it comes back very elevated. It comes back at 160 milligrams per grams of creatinine. As Dr. Karp mentioned, really elevated. So this is diagnostic of acute hepatic porphyria. At this point, you don't need anything else to diagnose the patient. This is our diagnosis, and we can really start treating our patient. This is to show the most common of the porphyrias, acute hepatic porphyrias, is acute intermittent porphyria. And again, why do we see this elevation in PBG or porphobilinogen and ALA? Is because in the heme biosynthesis pathway, in AIP, for example, there's a block of HMBS. HMBS is deficient or defective. And when the pathway is ramped up for whatever reason, and we'll talk about what our patient, why was the pathway ramped up, we see that blockage and upstream elevation of intermediates, which is PBG in our case. So we have a diagnosis. How do we manage this patient? And I like to think about management in several steps. And we'll go over all these steps, but really the most important and the first step in managing an AHP patient during an acute attack is to identify and eliminate any triggers for porphyria. And then we can look at, how severe is this attack, how do we do symptomatic treatment, how do we do targeted therapy, and not to forget, these patients all need long-term management after their acute episode. So starting with the very first step, identifying and eliminating triggers, and we already mentioned some triggers before, but what is a trigger? A trigger is anything in AHP that increases demand for heme synthesis or interferes with heme production. So in our case, there are some broad categories of triggers in acute hepatic porphyria. Hormone fluctuations is really the major one, the one that most of our women who have acute hepatic porphyria attacks have as a trigger. So a lot of women will tell you that they tend to get an attack in the luteal phase of their menstrual cycle because of the surge of progesterone during this phase. But even exogenous estrogen or progesterone can trigger an attack. Oral contraceptives can trigger an attack. The second category is nutritional deficiencies, which Dr. Karp mentioned, fasting, reduced caloric intake. They can increase the demand for heme, and that increases ALAS1 activity. So that is a trigger, fasting for religious reasons or intermittent fasting. We've seen this now sometimes with acute weight loss from GLP-1 receptor agonists, sometimes post-bariatric surgery. So that's a category. And then medications or drugs is a big one, and that includes alcohol, tobacco, illicit drugs, but also some routinely used prescription medications, sulfa drugs, for example, sulfa antibiotics. Our patient got trimethoprim, sulfamethoxazole, and that actually turned out to be a trigger in her case. But really have to be mindful about medications. And then finally, stress, which could be physical illness or surgery or even emotional stress can be a trigger. When we have to determine the severity of the attack, we think about mild and moderate just from the way our patients describe symptoms. So sometimes patients that have a known diagnosis of porphyria, acute hepatic porphyria, they'll call you and they'll tell you they feel like they're having an attack, but they're managing it at home. So the pain is not debilitating, there are no neurological deficits, there's no tachycardia, hypertension. But some attacks are severe, and these really, if you hear about a patient describing these symptoms, you need to bring them to the ED, you need to admit them, and this is where the pain cannot be managed at home. There are some neurological deficits that they are worried about, and there are severe autonomic features such as hypertension or tachycardia. Symptom management and supportive care strategies apply to mild and moderate and severe attacks. And again, the first step, we eliminate triggers, whatever the trigger might be. In this case, if the patient drank alcohol or somebody had a binge drinking session on the weekend, we talk about not drinking alcohol because that's a trigger in this patient, stopping medications that we know might be culprit medications, or if there was caloric restriction. But then what do we do for symptom management and overall management of attacks? And this is where it gets a little bit important because we know that some medications can trigger porphyria. So you might worsen an attack if you give the wrong medication. So coming to pain management, it is kind of futile to use NSAIDs or Tylenol in some of these patients when they're in an acute or severe attack because it doesn't do much. You really need opioid medications. A lot of EDs or house staff teams will hesitate to do this, but we need opioid medications at least at the beginning stages of the attack. Nausea and emesis is treated with chlorperazine or ondansetron. For agitation, we use chlorpromazine and oxazepam. Management of hypertension and tachycardia is usually done by either beta blockers, ACE inhibitors, or angiotensin receptor blockers, or ARBs. These are all safe in porphyria. Calcium channel blockers we know are not safe. They tend to trigger an attack, so we don't use CCBs to treat hypertension. Seizures, again, we do not use phenobarbital, we do not use phenytoin. Those worsen porphyria attacks. We can use diazepam, we can use clonazepam, magnesium sulfate is also safe. And then the hyponatremia is a classic feature of an acute attack of porphyria. And a lot of the times, this hyponatremia might be from SIADH or syndrome of inappropriate ADH secretion. And in those cases, it's important to identify that and treat it accordingly. So we'll talk about how our patient got treated in a bit. Coming to targeted therapies, carbohydrate loading is really the initial therapy. So if a patient is having an attack, we use IV dextrose in the form of carbs. We use D10W 300 to 400 grams per day. If the patient is having severe symptoms or is not improving on IV dextrose, we admit them. We have to admit them, and we then use IV hemin, which is really our most targeted therapy. And we use IV hemin through a central line or a midline in the dose of 3 to 4 milligrams per kilograms per day, mixed with albumin. What does carbohydrate loading do? So we know that reduced caloric intake can trigger an AHP attack. So we try to give calories back. And when we give carbohydrates, it increases ALAS1 expression by increasing PGC1 alpha expression. And glucose and carbohydrates decrease PGC1 alpha and downregulate hepatic ALAS1. This can be used in mild cases as a temporizing measure until hemin is available. One note of caution in carbohydrate loading during carbohydrate loading or using IV dextrose is that it's usually D10W. So we might increase the risk of hyponatremia when we are giving D10W. So we have to keep a close eye on the sodium. We also have to keep a close eye on the sugar to see if this patient is developing hypoglycemia. If the patient is unable to tolerate PO intake for many days, we also consider parenteral nutrition. Hemin, what does hemin do? Hemin represses ALAS1, which is the rate-limiting step in heme biosynthesis pathway. By that, it reduces plasma and urinary PBG and ALA. Any attack severe enough to require hospitalization should really get hemin. And hemin can resolve the attack pretty rapidly in 4 to 5 days. The typical regimen is 3 to 4 milligrams per kilograms body weight given IV as a single daily dose until symptoms resolve. And we really want to reconstitute hemin in albumin as much as we can, whenever we can, to minimize thrombophlebitis. Otherwise, we really should be using some central access, a central line to give hemin. So hemin is very beneficial. We know that from case reports and other case series. There was a survey of 108 patients from the Porphyria consortiums, and they reported that hemin was their most effective treatment. On the patient-reported efficacy scale of 1 to 10, hemin was rated 7.9, whereas glucose was rated 4.4. So that is our most effective therapy during an attack. And then finally, coming to long-term management. So once this attack is resolved and the patient is going home, we really shouldn't forget about bringing them back to a Porphyria center or to a physician that treats porphyria or can help the patient, monitor the patient over time. What the next steps involve is characterizing the type of porphyria, assessing if the patient might need prophylaxis with hemin or givosirin, which is an RNA inhibitor therapy for prophylaxis in porphyria, genetic counseling for the family, and then monitoring for long-term complications such as chronic kidney disease, chronic hypertension, chronic pain, and risk of HCC, as Dr. Karp mentioned. This is a multidisciplinary effort, involves hepatologists, hematologists, neurologists, nephrologists, and if the patient has VP or HCP, also dermatologists. And then finally, for severely affected patients that haven't yet developed advanced motor neuropathy, liver transplantation is also an option. So these patients need to be monitored over time to see if that might be an option. So wrapping up what happened to our patient, we diagnosed her with AHP. She was started on IV hemin infusions, led to gradual resolution of pain and autonomic symptoms. For tachycardia, she was started on a beta blocker. For the hyponatremia, she initially got 3% hypertonic saline and then DD-AVP, transitioned to urea and fluid restriction. After she got better in about a week, she was sent home, instructed to use carbohydrates if she developed mild symptoms at home, and then present to the ER if she ever developed persistent symptoms. Genetic testing showed that she did have an HMBS mutation, so she had AIP, and she now follows at a Porphyria center. So that concludes segment 2, and we'll be happy to take any questions.
Oh, we got some good ones here. No true false either, okay? For the first question, maybe this is Dr. Karp's question too. For how long after crisis are porphyrins elevated in the urine? precursors? Yeah.
That's a great question. Probably for weeks afterwards. And there are some patients who, even despite not having any symptoms, who have acute hepatic porphyria will always have high levels of urine PBG, ALA, and other porphyrins in the urine. So, but typically that, marked rise will take, a few weeks to come down, probably quicker with hemin.
I'll follow that up. If you see a patient with normal urine precursors and porphyrins, and they come to you and you don't have any genetic testing yet and they're asymptomatic, do you like repeating them at a certain time when they have symptoms? What do you usually do to tell that patient they do or don't have it?
So this is somebody who's coming who has a history of symptoms, neurovisceral symptoms, abdominal pain. They come to clinic for a question of acute hepatic porphyria, but their testing is normal. So, I will have them come back in. I'll put in a standing order so that they can come in and have, urine tests when they're having symptoms or when they present to the hospital. But oftentimes, patients may travel, from far away to come to our clinic, and I'll often send genetic testing, so I have it. We have free genetic testing. It's really helpful. So I'll often send it at the same time. But, I do ask patients to come back when they're symptomatic to recheck their urine.
Yeah, I do too. Dr. Mogi, so who should be the primary person managing these patients?
I don't think there's a right answer for that. I think we all can manage these patients, and we all should be managing them together, really, because there's so many different aspects to this condition, and we might have some expertise in different aspects of that condition. So just like our group, the consortium and the community of porphyria doctors, we all talk to each other. If I have a question now, Dr. Karp is studying reproductive health in AHP, so if I ever have a question about that with one of my patients, I reach out to her. And
if I have a patient with elevated liver functions, I'll reach out to you.
So I think everybody can and should really manage these patients.
And that's what makes it fun, too.
Oh, it does.
Yeah,
it does. Do you guys have neurologists at your program that you rely on too? They're very helpful too.
I reached out to our neurology group, and there's somebody who's interested. So it helps to have somebody who will look at these patients broadly and not have a regular neurological assessment, because their neurological symptoms might be different over time or might not be that obvious. So it really helps to have neurology on your team when you have a porphyria center or when you're assessing a porphyria patient.
Yeah, no, I agree with that too. And in terms of screening for hepatocellular carcinoma, someone says, what's better to use, ultrasound or CT scan?
So I think with regard to that, and Dr. McGuire, you can chime in too, but with regard to that, I think the ASLD guidelines still use ultrasounds every 6 months with or without AFP as the screening modality, the most effective cost-effective screening modality in patients. In AHP, we just don't know enough about this, and I think most hepatologists probably alternate a cross-sectional study with an ultrasound. So at least I do that for all of my patients. I alternate a triphasic CT or an MRI, and then after 6 months, I'll get an ultrasound. So that's what I do, but what do you do, Dr. McGuire?
Yeah, no, in Alabama, unfortunately, we're a little obese. And so I will do an ultrasound to start with, but most of the time they'll say increased echogenicity, cannot rule out focal liver lesion, we'll recommend CT scan. So then they're just on the CT scan yearly after that.
Correct, so you just have to go by the patient characteristics.
Yeah, unfortunately, yeah. In terms of long-term management, the risk of HCC, do we know why?
Do we know why?
Why are they at risk of HCC? I don't. Yeah.
So I don't think we know it completely, but there was that very interesting paper that came out a few years ago from this French group that showed that biallelic HMBS mutations, HMBS works as a tumor suppressor gene. So when it's mutated, it seems to increase your risk of liver cancer. So that was a very interesting study, and I think we are thinking on those lines as to there's something there with HMBS mutations, and we see this mostly in AIP patients with this high risk of HCC. So I think further work needs to be done, but it's probably the genetic defect itself that is increasing the risk.
Yeah, no, I agree with that. Well, very good. Well, thank you. So I will move to the next section. We'll talk about real-world implications of care, more treatments that are out there, and that's actually what makes it fun. Any disease you take care of, boy, when you get treatments and you can treat people, it's fun to offer them. So that's what we're looking for here. So this patient actually was sent to one of our GI doctors, and he's in clinic the same day I am, and he came over after clinic. He said, I think this patient had porphyria. And I go, no way. I said, how many times have you diagnosed porphyria before? He said, one other time in my entire career. And he's older than I am. So there you go. So it's rare, but if you don't look for it, you'll never find it, correct?
Correct.
Like everything else. So this 28-year-old woman who was referred to a tertiary medical center, UAB, for management of cyclic vomiting syndrome. And we see, too, also, a lot of times when patients get diagnosed, you guys have all seen this, boy, when they get diagnosed, sometimes they're relieved because they have a diagnosis, especially your comment, Dr. Karp, where they go 8, 10, 15 years without a diagnosis, you know what I mean? And boy, it's just so, you just feel so sorry for the patients when you see them that you're just happy to help them when you can. So in terms of this case, she essentially presented with recurrent episodes of nausea and vomiting, abdominal pain that would last days to weeks. Abdominal pain was described as severe, crampy, initially begins in the umbilicus, but then becomes more generalized. Can be as severe as 8 out of 10, usually followed by nausea and vomiting, reduced oral intake. Because of the nausea, emesis was non-bloody, non-bilious. Feels like it's starting to have another attack soon. When we see someone like this, does the location of the abdominal pain help with diagnosis at all? What's your both experience at all?
It can be anywhere in the abdomen.
Anywhere.
It's usually pretty diffuse, though.
Yeah, it is.
Periumbilical, yeah.
You know, when you see them in the ER and they're just writhing in pain, they just can't get comfortable, you know, but you feel a lot better when you do a CT scan and you see nothing there. You know, that kind of helps, but it can be unnerving when you see someone like that. So this individual had 5 previous hospitalizations in the last 4 years because they were for severe episodes. During these episodes, she was evaluated with multiple CT scans, MRIs of the abdomen, upper endoscopies, even had an ERCP or an endoscopic retrograde cholangiopancreatography, and no cause was identified. She required IV fluids, antiemetics, and extensive pain control with hydromorphone and gabapentin until her pain resolved, and this was during her last hospitalization because we had records for that one in particular. The other ones we had very little records on. You know, so this is cyclic vomiting syndrome. This is what it's supposed to be, where people will essentially, you know, feel good at some point in time, but then the symptoms return. And she was really just not so sure that was the right diagnosis. So it was her that pushed her primary care doctor to say, hey, can I just see somebody else? And her primary care doctor was very open and said, yeah, let's go see somebody else. So that's why the patient ended up coming to our clinic. So essentially, review of systems, left-handed weakness for a couple of months, dark urine, concern that she had a urinary tract infection. She also had hypertension for 6 years. And someone 28 years old, I think that's kind of a red flag. Why would someone 28 years old really have hypertension? She had the cyclic vomiting syndrome that was diagnosed after her 3rd hospitalizations about 2 years ago. Also had migraines. Medications, she was amlodipine, 5 milligrams per day for blood pressure, hydromorphone for her pain. Allergies, she said sulfa. She said, you know, one time and I took sulfa, I just didn't feel right. I actually had abdominal pain, and it was almost like one of my attacks, but I just couldn't tell for sure. So I just tell people I have an allergy to sulfa because I just never want it again. That's fair. Social history, she's single, not sexually active. She's working full-time as a banker, but is having difficulty working secondary to recurrent hospitalizations. She smokes a half pack per day and drinks alcohol socially with friends on weekends. In terms of her physical exam, blood pressure is 140 over 90, heart rate 98, afebrile, BMI is 24. She's no acute distress, tachycardic, but no murmur. Close to tachycardia, close enough. Okay. Bowel sounds are positive, tender to deep palpation, worse in the paraumbilical region, but no peritoneal signs. It's always reassuring with the no peritoneal signs, but still not definitive. And then the neurologic exam, it wasn't done by the GI guy, I must admit. Ended up going to neurology, okay? But our neurologist, he has clinic on the same day, so we got her in a couple weeks later. So notable for decreased strength, left relative to right distally, and she was right-handed. All sensory modalities were normal. Decreased brachioradialis reflexes in the left arm relative to the right. That a neurologist, that's not a GI doctor. There you go, okay? In terms of labs, sodium 131, kind of a red flag right there. Creatinine 0.9, glucose was 130, magnesium was low at 1.2, calcium normal, lipase was normal, albumin normal, TTG looking for celiac sprue, that was normal, CBC, DIF, LFTs, thyroid, iron studies, ferritin was all normal. Her pregnancy test was negative. So based on that, she had a urine analysis, and it was normal, and then the urine culture was also normal. At this point in time, that's when the gastroenterologist came to me and said, okay, what do I need to order? Okay? And we've all heard that, and that's okay. We're good with that. So we said porphyrin precursors, and as you see here, her ALA, and we've noticed too, we've had like different normal ranges and things like that. There are multiple different labs, as Dr. Karp mentioned, you know, and some of them are different, and they're not really standardized, and I wish they would be, but I think it's all based on the individual lab, and they really set their own guidelines as to what's normal and what's not. But her result was elevated at 72, normal being less than 7, so 10 times the greater limits of normal. And then porphobilinogen, normal being less than 4, and this was 104. So significantly elevated. And essentially, we've seen this slide already, but this essentially shows us genetic testing of the heme pathway, and she was positive for the HMBS gene. And as mentioned earlier, you know, this is a great thing to check for, especially if there's other siblings, and you want to make sure that they know their actual gene defect, and you can tell them, hey, you need to tell this to your siblings. If anyone had any symptoms, anything close to it, please send off and figure it out. And essentially, just how to manage recurrent attacks. What do we do? We essentially, as mentioned earlier, avoid precipitating factors. I won't go through them again. Pretty extensive list, which is good. Assist with pain management, antiemetics. The numbers are probably about 28, 29%, 30%, depends on the study, of people that are on chronic opioids use. Do you guys agree with that? Of people with acute symptoms? Mm-hmm. You know, I mean, it can be pretty high, unfortunately. Yeah. For recurrent attacks, we talked about carbohydrate loading, heme therapy that we talked about with Heman, and essentially givosiran's our other option. The issue with Heman that was mentioned earlier was the iron overload. Essentially, when you get a Heman infusion, you get 22.7 milligrams of iron with each one. That's a lot. I didn't realize it was that high, you know. And then givosiran's our next one, and this came out in 2019, and we'll talk more about that. So what's the data on Heman? Okay. Unfortunately, this drug was approved in 1983, okay? And really through the Orphan Drug Act for the FDA, the trials that were done were really just open label studies. And there are essentially over 100 patients that were involved in it. Some of them had multiple attacks, so there's 150-some patients, patient events that occurred as a result of it. And this is the data. Again, it's open labeled. They just thought, does it work or not? They asked physicians. They wanted to get their opinion. So it was just physicians saying they thought it worked at least in 85.5% of the time, okay? The other 14.5%, they thought it did not make a difference. In terms of chemical, what do we mean here? We're talking about urinary ALA and PBG. Again, it was different results in the labs and things like that, so it's just them saying, but they thought 100% of the time that they saw a dramatic reduction. And it doesn't always normalize, as we've seen sometimes in patients during an acute attack. It comes down, as we said, it's usually elevated at least 5 times, at least, if not more than that. But when you see it come down, it may be just a couple times elevated sometimes, and but it's still sure better off than when they started. So, but because of these 5 open label studies, this is officially why the drug got approved for use. In addition, there was, in 2000, the FDA kind of wanted to shut it down, and there was changing who was making it and where it was being made in a facility. So the FDA said, hey, you guys need to do a new study since all the original studies were done even decades before that. So essentially, this study was done by Carl Anderson, where they took it, and it was really just more for a safety. So that's all we're talking about is really safety. But the purpose of the safety study was just to show what really are the side effects. And so this essentially looked at side effects that are greater than 1% of patients treated with hemin. And essentially, if you see the side effects, headaches, pretty common. We all see that. In a pyrexia, 4.6% infusion site reaction, 3.6% phlebitis, 3.6%, a rash was 1.5%, and cellulitis was 1.5%. So these are the side effects, and these are pretty commonly seen, and we've seen them in most of our patients at one time. So it does happen, and there are side effects to it. So that's the data using hemin. What's the data using givosiran? This is a study. It's the ENVISION trial. It was done through the Porphyria Consortium. It was very well done. And essentially, they took 94 patients. Of these 94 patients, 89 of them were acute intermittent porphyria. The other 5, 2 were variegate, 2 were unknown, and 1 was HCP. And so essentially, of these patients, and pretty typical, I would say, of our population, average age was 37, and 89% were females. A lot of issues with abnormal liver tests that was seen like 37% of the time going into it. Other big thing was an abnormal glomerular filtration rate, which was seen like 36% of the time. Hypertension was like 27%. So common symptoms we see. The average number of attacks in these patients were greater than 8. I'm sorry, it was 8. You had to have greater than 4 actually to get into the study. To get in the study, you also had to have a good clinical diagnosis or genetic testing. And as I said, there were 2 that had elevated and urinary ALA, and how elevated are we talking about? It had to be at least greater than 4 times the upper limits of normal for diagnosis. They had to be off hemin also if they're going to be involved in this trial. So essentially, I have here the study design. The double-blind period we'll talk about first, and then there was an open-label extension period we'll talk about next. This is essentially the double-blinded, placebo, randomized controlled trial. And as you see here, the mean annualized attack rate and its components. So what was an annualized attack rate? What do they mean? Patients that were hospitalized, patient who went to an urgent care or an ER, or patients that required IV hemin. A lot of these patients will get it as an outpatient sometimes if they have a mild attack or even a moderate attack. They don't want to be hospitalized. In the olden days, we'd send them to our infusion centers and try to give them IV hemin to see if we can prevent a hospitalization. So that happened. So that's why that's included there too. So that was essentially the composite. And as you see in the placebo group, during this time period. It was 12.5 episodes of attacks in the placebo group. In the treatment group, it was 3.2, so this was a 74% decline. And then on the right side, you see the median annualized attack rate, and you see a 90% decline. So it was, during this time period too, 50% of the patients actually had no attacks whatsoever in the givosiran group. In the treatment group, it was like 17. So these are patients that are pretty sick, especially if you're talking about their number of attacks they were having annually was 8. This is confirmation, just showing, hey, we're given something, does it really work? And normal urinary ALA level in this study was 1.5, and you see essentially by 1 month in the givosiran group that they essentially really come down to normal by 1 month. It's pretty impressive when they get it, and it's actually fun to see. And then you see it still remains low throughout, and this was statistically significant throughout. So there's essentially an 86% decline in urinary ALA levels, as shown by the slide. There are side effects, just like there are with everything else. I think they're pretty manageable. Side effects, adverse events in the givosiran group was 90%. In the placebo group was 80%. Adverse severe AEs was 17% in givosiran, 11% in placebo. Any serious AEs, 21% in givosiran, 9% in placebo. Any AEs that led to discontinuation was 1 in the givosiran group and not in the placebo. No deaths. Hepatic issues occurred where you had elevated LFTs. It usually was AST, ALT. As we said, this drug essentially gets taken up through the ASGP receptor in hepatocytes, and through this receptor, it comes in. I have no idea why it causes abnormal LFTs sometimes, but it can. Usually when it occurred, it would be like 3 to 5 months after treating them. So I actually, when any patient I start them on it, I'm checking labs monthly just to make sure that their liver numbers are normal and stay normal throughout. You also probably, when you treat them, you need to follow and make sure their kidney function stays normal too, because there was some increase in serum creatinine or a decrease in GFR, and that was seen 15% of the time versus 4% in the placebo. Injection site reaction, 25% in the treatment group, 0% in the placebo. Nausea was 27% versus 11%. It's very interesting. The nausea is still there, and I think a lot of it has to do just with the nerve damage that's gone on from the elevated urinary ALA and PBG, or serum ALA and PBG, and I think that elevation just causes chronic issues, and I think that's part of the issue with the GI-related symptoms. Rash was seen 6% of the time, and fatigue 10%. Next, we're just going to talk about the open label extension period. So essentially, you had the patients that were randomized to givosiran, the double blind. They were asked whether they wanted to continue, and 47 of those patients, all but 1, agreed to do the continuation. In terms of the placebo group, they were asked, all of them agreed, and they wanted to go on and do the open label extension. So we'll talk about the open label extension now with this data, essentially. So this essentially breaks it up. You see in the first 6 months the double-blinded period, and then the open label extension period is after that, and you see that there. And they break it up into 3-month intervals, and they just say essentially a composite of attack-free patients. So again, it's the same thing: ER visits, urgent care, home IV heman, or hospitalizations. Those were saying that there were failures. So essentially they show it here, and you see with time that essentially in all the patients, all the patients got givosiran. that they actually do very well with it long term too, and it's been nice to see. So in terms of this study, again, there was not anyone to really compare to, so these are just side effects too that we see, and I listed the ones really of interest. Again, the injection site reactions we know about, renal, hepatic, we talked about. Increased blood homocysteine levels is an issue there too, lipase elevation, pulmonary emboli was seen, and aortic dissection, whether it's related or not, it's hard to know, and 4 patients were discontinued, and it lists as why there, okay? The nice thing, we all get, it's a rare disease. There's so much in the world that goes on, and this is one of the most beautiful things in that there are associations, there's nonprofit patient support groups out there, and those patient support groups really pull everyone together and let them know they're not alone. You know, and here's a list of some of them, depends on where you are, but it's just so great to have these support groups out there that we really appreciate them, and they make it easier for the patients to understand that they're just not alone. And so I truly appreciate all of these groups out here, and I think we'd be lost without them, right?
Agree.
I know, and even when you get patients referred based on these groups too, which is great too. So patients will reach out to them and say, hey, I think I have it, and then they'll message one of us and say, hey, we'll see them, let's make it happen. So it's very nice. So we appreciate these groups. Make sure all your patients are aware of them just so they can use it as additional support. So now we're coming to the question and answer sections, okay? Again, no A, B, C answers, okay? Maybe we won't get through all these, but we'll do the best we can. The next one then. So injection site reactions. How do you treat it? I know how I treat it. You want to answer? You guys have a bet? I'll tell you what I use at least. And it's all based on biologics, right? And that's what I guess I've used. Cold compresses, okay? And I also, topical steroids I've used. If there's itching associated with it, antihistamines. Okay, I don't know if you guys have tried anything else.
That's what we've done as well. And, you know, usually, oftentimes it can get a little bit better. We rotate sites, but I've had patients, you know, take Benadryl 12 hours before they come in. So we try to strategize. I haven't had anybody who's had to discontinue because of the injection site reaction.
Yeah, I haven't.
I agree. It's not been a big issue. And treatment is fairly simple, just like any other infusion site reaction. But it's not been a limiting issue in any patient.
Yeah. Good question here. Can givosiran affect HCC probability? Dr. Mogi, we hope so.
Would it affect, I guess, reduced risk of HCC?
Yeah, I think so.
Yeah, I think so.
Yeah.
A good thing to study for the future, you know.
Yeah.
I think it's a good study to do to see if it reduces HCC risk.
Next question is, what is the recommended drug for iron chelation if iron overload occurred in porphyria treatment?
It's a great question. You know, so these days we don't really see iron overload to such a degree anymore because of givosiran. As Dr. McGuire was saying, you know, a vial of heman has about 25-ish, you know, milligrams of elemental iron, and you really have to have a lot of that. If you're a young menstruating woman, you may lose it with your menstruation. So it's rare nowadays, really, to see patients with such frank iron overload that they need chelation. You know, I will still try, if they're not anemic, I'll still try some phlebotomy first, because the iron chelator drugs have really, you know, pretty bad GI side effects, and people are hesitant to take them. I've had a lot of issues with compliance, you know, in other situations, just because they're really, you know, they can be difficult drugs to take. You know, in terms of porphyrinogenicity, I'd actually have to look at the database to see. Deferoxamine should probably be fine because it's sub-Q, but I'd have to look up the other ones off the top of my head. I'm not sure.
Yeah. Okay.
This, I think, is an interesting area because we've done this study with just a few patients, looking at patients who got hemin repeatedly. And ferritin almost seemed like it was, when we saw the elevation of ferritin, we thought some of them might just have an elevation as an acute phase reactant. Because over time, if you followed the patient, the ferritin came down. So it didn't seem like a permanent iron overload, but again, something that needs to be studied with more patients. And it's now we don't see that much of repeated hemin administration. But we've been able to manage patients without having to chelate them by just monitoring and following, and they usually come down.
Yeah, but iron, I assume, just gets redistributed somewhere, right? Because you really can't get it out without phlebotomy, correct?
Yeah, there's no good way to get rid of iron.
There's no good way.
Very good.
Menstruation.
Yeah.
Okay. Urine color can be normal in an acute period. Oh, that's a good question. I guess I see where they're coming from. So we think the purple color that occurs is from porphyrobilinogens breaking down, correct? And I guess when they don't notice this, it's purple right away because essentially the PBGs have to be oxidated, I assume, and it takes fluorescent light to make that happen. So usually, we'll tell patients, or you have residents, right, you're working with them and you tell them, hey, grab a sample of the patient's urine and just put it underneath the fluorescent light and we'll look at it the next morning.
Correct.
So I guess the question then, so it doesn't turn, it's not purple during the attack.
It doesn't come out purple, correct. So I think if you're getting a patient history, the patient wouldn't tell you that it comes out purple or it comes out reddish or any other color. It probably comes out normal, and if it just sits there, it will turn color. So it's hard for patients to see that unless their urine has been sitting for a while. Yeah.
I did have one gastroenterologist call me because he admitted a patient. They put a Foley catheter in. The next morning, when he went to the bedside, he said, your urine's dark. And that's what made him think of it. But he never would have, no one in the ER thought about it until the urine sat in the bag. And
for a while.
I guess there was enough light to change it, which is really kind of cool. Yeah, that's really cool. Okay, if genetic test is positive, but the patient is asymptomatic, do we consider any treatment at all, like maintenance treatment of some sort?
That's a great question. So if somebody, guidelines today would say that if somebody is asymptomatic, even if they have high levels of, urine, ALA, and PBG, that they would not qualify for treatment. We really treat based on symptoms. We might be careful about what medications are prescribed to them, or if they're a young woman, in terms of birth control, pregnancy, certain counseling. And once they're over the age of 50, we don't really know, should we be screening these patients for HCC? We do, these patients who come into our clinic, especially if they have higher levels of, PBG and ALA in their urine. But what Dr. Moki was saying is, maybe some of these treatments that we have might be able to prevent complications such as HCC, CKD, et cetera, in patients going forward. But in today's day and age, we really treat based on symptoms.
Yeah, I agree with that.
Yeah, and just to clarify, so if there's a genetic defect but no biochemical evidence, like no elevation in PBG in the urine or ALA in the urine, then we don't treat at all. That's latent AHP or latent AIP, or it's latent disease because the penetrance of the mutation is so low in AHPs. But if there is increased PBG in the urine without any symptoms, I don't think we have good answers for that right now.
Yeah, I agree with that. How long is givosiran given as maintenance treatment?
Right now, indefinitely.
It's another area that's up there. So there's a difference between, how we practice in the U.S. and some centers in Europe. But, unless somebody is having side effects from the givosiran, which again are quite rare, we usually continue it indefinitely. If patients have, marked reduction in their attack rate and these terrible symptoms, it's hard to discontinue the drug. There are centers in Europe, in the UK, in France, who are trying to see whether or not we can get away with less gavocerin, so stopping it after 2 years once a patient is very well controlled and once their urinary biomarkers have really come down. So again, it's something that we don't know the answer to.
Yeah. And then sort of follow up, when would you consider discontinuing? You kind of answered that.
One question is pregnancy also. What do we do in pregnancy? We don't have great, we don't really have any data on gavocerin in pregnancy, but if you have a young woman, again, it's these young women that we see, she's very well controlled on gavocerin, she's been on gavocerin for 5 years and she wants to get pregnant, what do you do?
Yeah, I don't know. And same with breastfeeding, we don't know about. Yeah. Would you combine gavocerin with Heman prophylaxis for patients not responding well? I haven't done that yet. We have patients sometimes, in the study it showed too, where they had an attack just after starting it, and I've had patients too, where you bring them in, you give them IV Heman, but I guess I've never sent them out to do both.
I agree. I don't think we've planned to do both for any patient. The plan is to be on gavocerin prophylaxis. Usually they are controlled, but if they seem to have a breakthrough attack or they have breakthrough symptoms, then we give Heman as an additional therapy while they're getting their gavocerin prophylaxis. So.
Okay. Yeah. The next question, when given Heman, do you use albumin?
Every time.
Yes.
Yeah.
It really reduces the risk of thrombophlebitis. We actually don't routinely give Heman through a central line. We give it peripherally in clinic with albumin, and it's generally very well tolerated.
I've never had the courage to do that. Good for you. No, I'm glad you did. No, that's good to know. We'll try it.
Yeah, no, it's much easier. Yeah.
I guess you said midlines, we put PICC lines, midlines, whatever you want to call them.
lines,
and I think that works pretty well too.
Yeah.
Okay, so you think I use
We do it all the time.
That's good to know that you.
Yeah.
Do you care what gauge?
I have to ask the nurses what they do, but we haven't had any issues. I haven't had to put in a port or a PICC or a midline in a long time.
Wow.
Yeah,
very good.
yeah.
Okay, good. Okay, I like it. Okay.
But again, a lot of these patients aren't getting, repeated cycles of Heman, and because they're on gavocerin, they're very well controlled now. Maybe they'll come in with a breakthrough attack, but they often don't have, such scarred down veins, as we used to see. So.
Yeah, and sort of leading to that, we've evaluated a few people years ago because their veins were really so scarred down that they said, hey, their only option is transplant. We ended up not transplanting them because it was right around the time that gavocerin was coming on, so we said, well, let's wait for this, and we've put them on that, and they've done pretty well with it, so they haven't needed transplants, but we've considered it. Dr. Mogi, you've transplanted someone when you were at Pittsburgh. You heard about them with?
Yeah, and that was for severe AHP, severe repeated attacks, and they hadn't still developed any neuropathy, but they had neurological symptoms with each attack. So I think that's the right time to think about transplant rather than once you have developed some of these long-term complications, because those many times don't reverse. The chronic pain then doesn't reverse, or neuropathy won't reverse. But if you do it at the right time, you'll help prevent it, and patients do very well with transplants. So,
yeah. No, that's fair. And I think we did pretty good. In terms of patients, what patients do you use gavocerin for? I guess that's a question, because when the drug came out back in 2019. It was very similar to this trial. It was anyone who was using Heman chronically, anyone who was getting frequent attacks. I don't have a cutoff, so it was the sickest of the sickest patients, because any new drugs, you want to make sure that it's going to work. And I did a couple, and you go, boy, it's working. So now I'm taking people with less attacks and things like that and giving it to them, or even someone just with chronic pain and things like that associated with it, but really has only been in a hospital, I think, a couple times in their lifetime, and I've given it to them, and I guess I've been impressed to see them get better too. Comments on that?
Yeah, I mean, the trial really in Vision 3 was 4 attacks in 12 months or 2 in 6 months, but you don't want to necessarily wait for 4 attacks. If somebody comes in and she has a severe presentation with press and seizure and hyponatremia, I mean, can you really wait, for 3 more attacks? So, we have a low threshold to discuss gavocerin. I've had a few patients who say, no, I want to manage it the way that I have. I don't want to come in every month for an injection. But I think it's worth a discussion. And we've also seen that this medication really has very few side effects overall. It was approved in 2019 and very well tolerated. So to have that sort of steady state control, and also it makes us feel good to see those urine levels go down. As we were saying, I do think that that's protective against these longer-term complications. So I do have a low threshold to start. Again, women who are thinking about becoming pregnant and stuff like that, it's a little bit of a more nuanced conversation, but that's how I feel.
No, I agree. I think the trial had to choose patients with some certain number of attacks and such. But the proof of the principle was that gavocerin helps prevent attacks, and we don't want to let patients have 4 attacks before we start preventing them. So, and most patients have been receptive to, if they've had severe symptoms or even one severe attack, they have wanted to do something to prevent the next one. So they've been receptive to gavocerin prophylaxis. The usual issue is coming in every month, missing a day of work, but if we work around that, most patients get on gavocerin if they've had a severe attack.
Very good. Well, guys, thank you very much. Sorry, we're out of time. We said inclusion, so really we want you to think about all your patients, okay? And low threshold for sending urinary ALA and PBG, okay? And then know there are treatments out there, hemin and gavocerin, and they're excellent treatment options. And think long-term how to prevent kidney problems, liver problems, and also worry about risk of hepatocellular carcinoma. So, guys, we want to thank you for all your time and for participating. And please, if you want to get credit, please go to the QR code listed here. Thank you very much, guys. Have a great day. Bye-bye.
Thank you.
Thank you.